I wouldn't be mistaken in saying that this is one of the most interesting and anticipated sessions for our forum. Those of you who joined us yesterday, maybe you noticed that almost every presentation we discussed the issue of access to medicines and the need for their transparent and fair assessment. So in many ways, today's session continues yesterday's discussion. But we focus specifically on how HTA can help us make evidence-informed and sustainable decisions for orphan medicines. I'm very pleased that we have such strong representation today, and I'd like to sincerely thank all colleagues who responded to our invitation and agreed to take part in this session. Today, the key BRICS countries are presented, and I hope this will be our first, but certainly not our last meeting. I very much hope that we will continue this dialogue further, and we will develop our cooperation and also involve the remaining BRICS countries in this important discussion. HTA for orphan medicines is one of the most challenging areas for healthcare systems in the world. Unfortunately, traditional HTA methods often do not work well for orphan medicines. In many countries, the most common response is to lower evidence requirements, accept more limited clinical data, or increase cost-effectiveness threshold. But is this really a solution? Because when we lower our requirements, it means that we have a higher probability to make mistake. It doesn't solve the methodological problem. The number of orphan medicines is increasing, and we need to adjust our methodologies to these types of medicines. We need tools that can capture different dimensions of value for orphan medicines, reflect the specific nature of rare diseases, and address uncertainty in a structured way. So before giving the floor to my co-moderator, I would like to say that it's a great honor for me that Dr. Mohamed Al-Khaldi agreed to join and co-moderate this session. Dr. Mohamed is leading a very interesting project on the assessment of HTA systems in different countries. This is an important and highly relevant methodological task, and I'm honored to participate in this project in the UAE on behalf of Emirates Health Economic Society. So I also asked Dr. Mohamed to briefly introduce this project today, because I hope that CIS countries are listening to us, and maybe they will be interested in conducting such kind of project in their countries. I think it could be very interesting to compare CIS countries between each other and to compare to other countries. So, Dr. Mohamed, welcome, and the floor is yours.
Thank you so much, Dr. Maria, and thanks for the speakers who are joining us. Good morning, good evening, and good afternoon. So you are joining from different parts of the world. My name is Mohamed Al-Khaldi. I'm assistant professor at Canadian University in Dubai here. And also I'm the regional coordinator of the Global Health Network that is affiliated to University of Oxford, as well as working with McGill University, where we started the multi-country HTA system analysis. So the first idea of initiating this project is to understand how the HTA system can be, assessed, analyzed in order to strengthening the HTA system pillars, whether governance, resources, stakeholders, evidence-based, integration into the policy-making processes, and also how the assessments and the evaluations are being implemented within the healthcare system. So we started with including 7 countries, with different level of low-income countries classification. We targeted Switzerland, Canada, Brazil, Palestine, Lebanon, Jordan, and Tanzania to analyze and to understand these HTA healthcare systems within these countries. And we use different tools mixed tools, qualitative and quantitative. And the qualitative, it was developed by WHO, but we adapted this tool. It is actually designed in order to be did across and all HTA operations, functions, and the processes technically from the technical perspective. Additionally, we added the qualitative tool, which is interviewing experts from different healthcare sectors, private, academic, NGO, and also ministries of health or health authorities in order to understand the HTA from policy perspectives. I'm so glad that this session is really targeting the HTA from policy perspective, but also we need to make an emphasis on how we evaluate the HTA system. This is very limited area of research in HTA that we need to collaborate and to invest more in research collaborations in order to regularly analyze our HTA systems in different countries or across the context. So what we saw in our result, there are many differences and similarities across the 7 countries. The first things that we saw or we reported, countries such as Canada, Switzerland, Brazil demonstrated strong institutionalization, higher awareness or understanding of HTA concepts and purpose, and also more established HTA structured and the governance systems, although they are facing a lot of challenges such as decentralization, coordination, funding, and equity considerations that should be integrated into the HTA systems and the structures. For example, in the other side, Lebanon, Jordan, Palestine, Tanzania, as well as UAE, the project that we are now introducing to the country or being implemented in UAE. This is the 8th project that we implemented it in the Middle East. We actually saw an early transitional phase of the HTA being implemented in the healthcare system, limited funding, insufficient technical capacity, where we actually reported weak policies and regulations issues or components within the healthcare system, as well as inconsistent implementation levels within the healthcare system. So the most importantly, that we also initiated an ongoing scoping review to explore, to map all AI and digital technologies that can be used in fostering the HTA processes. Now we are conducting this scoping review project in order to get clear, robust evidence and answers for how to use the AI, where to use the AI in and for HTA across the globe. So this is a global scoping review that is expected to be published in 2 or 3 months this year. So what we saw in this scoping review, the initial findings, that strong potential of AI to enhance the evidence generation, evidence synthesis, or maybe evidence, to be integrated into the policymaking processes, while also identifying challenges of using or harnessing AI in HTA or for HTA. We actually found issues like governance, transparency, implementation that should be considered when we apply or when we actually adopt the HTA for digitization or automation of the HTA. So this review informs the future of the healthcare strategies to be more adaptive, to be more data-driven, and also equitable HTA system. So I will stop here. I'm happy to provide more information about these projects, the 8 projects in the 7 countries for the first stage, as well as the project that we are implementing in the UAE. So I just want to share one slide that summarizes the whole project that we actually implemented. This is something that that we built like a framework that can be actually applied in all contexts or countries, targeting three different journey or stages of the journey. Analyzing the HTA healthcare system, understanding it, and then we move to strengthening that system, taking into account the HTA foundations such as evidence-based and policy-relevant issues, transparency, multidisciplinary accountability, conceptualization and understanding of the HTA concept, purposes and application, efficiency, effectiveness and equity, and finally the institutional trust and innovation. And we move to the upper level, which is the key pillars of the HTA system that should be actually strengthening in order to have well-established, responsive, and integrated HTA system. So I would like to thank you, Dr. Nari, and your team for this great work. And I'm happy to co-moderate this session in this event. So I think we need to move now to the first speaker of this session, which is Dr. Dr. Everton Nans de Silva. He's coming from the University of Brasilia to give his speech on this session. Over to you, Dr. Everton.
Many thanks, Mohammed, for the invitation. I'm very proud to be here and share some experience from the Brazilian perspective on orphan drugs for reimbursement in Brazil. I just share here my screen. Just a moment. Can you see my screen?
Yeah, we can see it, Dr. Everton. Go ahead.
Thanks a lot. So this just an overview how reimbursement of orphan medicines in Brazil and focus specifically on HTA. I'm from University of Brasilia, and this research I'm presenting here is part of a big project here in Brazil that is led for National Institute of Cardiology, that the PI is Marisa Santos. And so just to give some overview of Brazil, you are the largest country here in Latin America. You have our organization is a federation, and so you have one national government. Also, you have uh, you have also state government and municipal government, and so this also allowed each one of this government to incorporate technology in the public health system. They have autonomy to do that. And you are a upper middle income country and with a lot of disparities, as you can see here in the Gini index. Also, you have a public health system that follow the universality, comprehensiveness, and equity, and also all incorporation that is put in the SUS, our public health system, is free of charge at the point of service. And also you provide pharmaceutical assistance free of charge for every Brazilian or anyone that stay in Brazil. And so just to give some figures here from the SUS, you have about almost 60,000 health team at primary health care. That is our main strategy in primary health care. And you have millions procedures, outpatient procedures, in fact, 5 billion outpatient procedures and 14.6 million hospitalizations every year. And that is for 2025. And specific for health technology assessment, that is the main criteria that you use for reimbursement in Brazil. Also, you have a law, a national law that regulate this process. And what it means for health technology assessment? use evidence for safety and efficacy that is came from systematic reviews, efficiency with cost effectiveness, and also affordability with budget impact analysis. And so you have a commission here in Brazil that has about 17 members, and they analyze all this evidence for each health technology that is demand for evaluation. And this commission have a meeting, a decision every month in Brazil. And so you have about 15 medicines, drugs being evaluated each month in Brazil. Every year, sorry, every year in Brazil. And so here is the just summarization of that. And so we start here with safety, efficacy, cost effectiveness, and budget impact. So the CONITEC, that is National Commission, has from 6 to 9 months to take this decision. Also, you have some criteria here specific for cost effectiveness threshold. And so this one is from 8,000 to 32,000, and rare disease or orphan disease generally is the top threshold here in Brazil. Also for ultra rare disease, you have maybe not defined the threshold, also could be higher than this one, depend on the previous evidence. And so in Brazil also you have like a public consultation about all CONITEC, this national commission here in Brazil, do all this critical analysis about the quality of the evidence, also issue a preliminary recommendation. And this preliminary recommendation also you can open for the society, and they can provide additional evidence or also the experience for patients or health workers that lead with this disease. And so after this public consultation, you have the final recommendation that could be positive or negative. And the Minister of Health that take the decision, the final decision, but they are very aligned with the recommendation of this commission here. And so once the drug or the orphan medicine are incorporated in Brazil, you also need to include in the clinical practice here. That is clinical guidelines for that. And so you have several example of disease that has these clinical guidelines here. And also by law, you need to make available these drugs or any other health technology from 6 months from the decision of incorporation. And so that is the time you need to provide, in fact, free of charge these medicines or any other health technology. But also you have do some research from this technical recommendation from CONITEC, and you see for a very rare disease or ultra rare disease, you have other criteria that CONITEC also include in this report. The rarity and severity of disease also is mentioned as one additional criteria for that. So you know that you have some not very high quality for some evidence related to rare disease. And so if you have more information about the rarity or severity of the disease, also you could have a more positive evaluation for these health technologies. Uncertainty about evidence also is mentioned in this technical report, and there is some balance on that. specific if you have a therapeutic advance. And so even if the evidence is not a high quality, but if you have some information that you have a large therapeutic advance, maybe this also is more favorable to these medicines. Also, you have see some humanistic and social values consideration in some technical reports. If the technology of disease has a large socioeconomic impact on this patient and also in families. Also, you have the opportunity to take more information at patient reported outcome measures, and they also can fill some gaps that you cannot find in the literature, for example. In Brazil, also you have a lot of patient association that it has someone has a large influence on the decisions or in the government, on society, for example, in more general, and also they have some role in the decision. So these stakeholders is engagement with this uh, public consultation also can reverse a negative reimbursement decision for that. So you have some cases in Brazil that Conitec start with negative recommendation, but after the public consultation, you change the recommendation and also has a positive uh, recommendation for incorporation on that. As a key takeaway, say I know that is a very short time to see all these figures here, but health technology assessment has been the main criterion for reimbursement in Brazil. So you have this three evidence: clinical evidence, efficient evidence with cost effectiveness, and also affordability with budget impact. Budget impact is a really a breakdown point here in Brazil. And so as you have a very limited budget for pharmaceutical assistance here in Brazil, and when you have a large budget impact, so this could decrease the chance to be incorporated in public health system. Rare, ultra-rare disease impose a substantial financial burden here in Brazil, uh, especially for genic therapeutics here with these new uh, drugs so expensive. And also, you have this, is not a formal criteria like a multi-criteria decision analysis, but as you see in the technical report, there is a lot of other uh, other information that the Conitec takes in consideration. So it's not just HTA, but also other criteria that you can also have a positive decision about reimbursement. We are using also risk sharing agreement here for some specific drugs, especially for rare disease. But you have several challenges here with the legal issues. And so our law and our constitution should be there is some challenge to try to implement this risk sharing here about transparency and also how to share this uncertainty with pharmaceutical companies, for example. And so because that you have a very few example. Zolgensma is one of the cases that you are using risk sharing agreement, but you need to overcome this challenge to try to use better this one. And so I would like to thank you for this time and opportunity to talk about the HTA in Brazil. Many thanks.
Thank you, Dr. Everton. We really appreciate that you agreed to participate today because of the time difference. We understand how inconvenient it is for you, but it's very difficult to find proper time slot when we need to combine China and Brazil in one session. So it's a challenge, first challenge to work within BRICS. So it's very interesting your experience, and just a short question. I understand that we have time limit, but I can't ask this regarding the MCDA. You mentioned that you need to take into account different aspects, different dimensions, but you don't use MCDA. Is it because it's methodologically difficult to implement it on a system level, or you don't see the need for this because you are able to structure this deliberative process without MCDA?
Thanks for the question. I think you have a different challenge for that. Also, the transparency, how you use this one, I think is the main issues. There is no such a guideline. How can I analyze rarity or severity, for example, and how further I can go with a very limited evidence on efficacy, for example. And so we are discussing here in Brazil how to implement a transparent guidelines to use all these criteria for HTA. And this is a big discussion here in Brazil. And so you don't have agreement on that. And but also what I can see here in Brazil, the CONITEC, this National Commission for recommend incorporation, reimbursement or not, is very open for discussion with academia and also with other stakeholders to try to find a way how you can use this other how to implement multi-criteria decision analysis here in Brazil. But also you need to have more time to see how to implement this in a transparency way.
Mm-hmm. Thank you, Dr. Everton. I understand that we didn't cover important methodological aspects, and our suggestion is that we continue our work after this session, if you agree, because I think it would be really very interesting to prepare article, the comparison of HTA approaches across BRICS countries, and I also hope that our colleagues also participating in this session, they will join us because now we don't have time to cover all the aspects, but it's really very interesting and we can share our experiences. And we need to move on, and I'd like to present the next speaker from China, Professor Yingao Chen. He's Professor of Health Technology Assessment, Fudan University School of Public Health. Please, Dr. Yingao.
Yes.
Dr. Yingao, sorry, we don't hear you now. Just a moment.
Excuse me, could you make sure you are in the English channel, Professor Chen? Could you move to the English channel? It's either globe button or three dots button, then it's more, and then you should select English. You should stay in the English channel for the audience to hear you.
select.
Can you?
Yes, yes, we hear you. Thank you. It's okay.
You can hear?
Yes.
Okay. Can you see the screen? Hello?
Yeah, we can see your screen. Go ahead, doctor.
Okay. Yeah, that's my talk is that's HTA on that's rare diseases. So that's a very briefly introduction of China, and the population is 1.4 billion, and that's about 65% in the urban area and 35% percentage in the rural area. Population above the 65 years old already 15%. So I think and in China is also aging and quickly. For health expenditure, I think that's the total health expenditure share of GDP about 7%, but the per capita that's health expenditure quietly is very low. It's just 550 US dollar per capita per year. So in the total health expenditure structure, government expenditure about 27%, social health insurance expenditure about 46%, and also out of pocket is about 28%. So that's, I think, is general. That's China's and that's the background. So focus on the rare diseases, and China has a large and rare diseases patient population. Globally, about over 300 million people are affected by more than 6,000 rare diseases, and that's about 72% are genetic and about 70% in the beginning in the childhood. In China, I think because the health expenditure for health is very limited, and I think and is also insufficient resources, and that diagnosis and treatment face a lot of challenging, including uneven resource distribution, limited diagnostic capacity, and inadequate drug availability, insufficient data, and the shortage of the trained professional, and weak and coordination. That's the mechanism. So that's the picture show. That's the in China, and in the 2018, and the Ministry of Health released the rare disease catalog, and including 121, and in the year of 2023, and that's a category increase about double, and that's the total number is 207. So in the list, that's rare diseases can get more support by the public and health services and the public and the medical insurance. And in China, we also established China's rare diseases and infrastructure led by the Peking Union and Hospital in Beijing. So that's this and the consortium, and already that's cover about 324 and hospital in the beginning are right now about 420 hospital in China. So just very briefly talk about the rare diseases. That's just the diagnosis and treatment and the laboratory network. So that's including the rare diseases clinical services, and including the how many number of diseases managed, how many patient volume, and diagnostic confirmation rate, and also have provide a teleconsultation participant. Yeah, because some hospital that's the capacity limited, and also the patient is very rare and scattered in different the area. So that teleconsultation is very important. So that's include the number of consultation and the response timeliness, and also talent development. They have a lot of training workshop and training that as professional to increase their capacity to diagnosis and treat that's rare diseases. And also two-way referral implementation upward. And so if have found some patient with some maybe and suffer some rare diseases, but cannot diagnose it, then referral to the tertiary hospital, and a downward referral just for the treatment or those kind of follow-up. And also case registry quality and also capacity buildings. So we also have the reward and mechanism or penalty and the mechanism, especially for those and network hospitals. And multi-level medical security for rare diseases in China. So some, and I think we have basic medical insurance and layer, but also commercial medical insurance layer, and also medical assistant layer. So commercial health insurance mainly depends on the individual pay, but the medical assistant like a safety net for all those kind of people with rare diseases. But some and drug and within the NRDL, that means the National Reimbursement Drug List, and but some is just out of NRDL. So that's, and we can see some cover outpatient or the outpatient catastrophic and medical insurance, or some city inclusive insurance. So those kind of a multi-layer medical insurance for rare diseases. And some different provinces or city, they have some special and mode and for rare diseases. And for drug and mainly and China, we have the NRDL and the price negotiation every year started in 2017. And after that, every year, and we have those kind of new drug can be included in the NRDL list. So I think the NRDL negotiation organized by the National Medical Insurance Authority with expert review and price negotiation based on safety, efficacy, cost effectiveness, innovation, equity, and fund affordability. Successful products included in NRDL list. So that's just the basic procedure. So for NRDL list, so we summarize the dynamic NRDL updates every year. So this slide just all the NRDL updates and for every year, and how many drugs included and how many drugs are removed. But we can look at the rare disease drug and they're included. So in the year and the beginning and that before the 2017, only 23 rare diseases medicine included in NRDL. So every year we can see more of those drugs included. And so I think in the procedure and the NRDL list, and give a lot of special those kind of a policy for rare diseases and medicine. By 2023, about 100 rare disease drug has been included in NRDL, covering 42 rare diseases. The 2025 updates added additional 10 rare disease drug to the basic NRDL. And also the other thing is introduced the first commercial medical insurance on innovation drug list, including 19. So that's 19 for the commercial medical insurance and the list. So that's the basic NRDL list and for the rare diseases. So that's just a value framework and including safety, efficacy, economic value, innovation, and equity. Because of timing, I don't want to go through very detailed for the different kind of dimensions. So this is just the HTA procedure and for the innovative drug and included in the NRDL list. So I think all those and the rare diseases drug all go through those kind of steps. So the first step is just especially and just evaluate those kind of clinical and value for those diseases, and the stage 2, and especially for the cost effectiveness and budget impact analysis. So I think related to the rare diseases also have some special point. For example, the first is small sample and also single arm trial. So that's challenging for those kind of HTA dossier and review. But I think the government give more and flexible policy for rare diseases drug. And the second is high annual treatment cost and economic modeling and budget impact analysis, inform base price and fund eligibility, and also give some higher ICER threshold and for the rare diseases. And the equity is a very important and element. So those kind of unmet need and pediatric genetic diseases, rare diseases, coverage, and also social value equity, and give some credits for those rare diseases drug. And also evidence continue after access because we use real world study or data, long-term effectiveness, and try to just supplement those kind of efficacy, maybe evidence and limited. And so that's the use those RWE just strengthening their effectiveness and validation. So I think the challenge for in HTA for rare diseases, maybe the institutional gaps. So maybe and we have a specific policy for rare diseases, and also the capacity gaps, and also not too much and knowledge about the rare diseases and what's kind of the disease burden, and also the data access limitation, especially for the rare disease, not too much and epidemiology and safety or those kind of data, and also methodology and quality gaps, and also evidence integration challenging. So I think and for rare diseases, and we have those entry appraisal, but maybe the RWE and the generation and just supplement those kind of data, and also the evidence is quite very important. Also, and just for those radical and reassessment after entering an idea list. So we hope and maybe the BRICS and we can have more collaboration and share evidence and HTA method and rare diseases and access. For example, like actionable cooperation agenda, minimize data sets and share registry and RWE or RWD and the methodology consensus and the value appraisal, payer dialogue and access, and also policy output for rare diseases, comparable evidence base, adapted and orphan drug HTA, and entry uncertainty management and post-access reassessment. So I think and we collaboration, maybe I think the RWE or RWD, and I think we can work together, have more RWE and evidence generation, and also stakeholder dialogue, and we can to do some strengthening BRICS and HTA activities. So I think the rare disease cooperation and to connect evidence generation with reimbursement appraisal, multiple layer payment, and but also I think that's MCDA is also very important, and try to just synthesis and different dimension and into the final, that's the recommendation. So because of the timing, and I just very quick and introduce that rare diseases drug and in China. Okay, thank you very much.
Thank you so much, Professor Chen. It's really interesting to get this unique experience on China, which has really mega healthcare systems. And thank you for emphasizing on the multimodal medical security practices, as well as the clear integration of rare disease in the HTA processes in China, the significant expansion of the coverage for rare disease over the time, as well as highlighting the key institutional capacity gaps. And finally, the importance of collaboration, further collaboration that can be considered, especially in real-world data registration, generation, and integration, etc. This is a golden opportunity to invest our efforts in it. So thank you so much, Professor Chen. Now, I'm very pleased to introduce the third speaker, my colleague, Dr. Kifah Al-Qawasmi, HTA lead from Department of Health in Abu Dhabi. The floor is yours, Dr. Kifah. Thank you.
Thank you, Muhammad. Let me try to open the video. Can
Yeah.
you hear me?
Yeah, we hear you very well.
Okay, so I'll share my screen. Yeah. Would you be able to see the screen?
Very visible. Go ahead, please.
Okay. Thank you for the invitation and for Abu Dhabi to participate in such a forum. It's a very good opportunity for us, learning opportunity, areas for collaboration in the future, and of course to network with all these esteemed speakers. So thank you again, Nuria and Muhammad, for this invitation. I'll be giving insights on the health technology assessment in Abu Dhabi. Abu Dhabi, if you haven't, if you know, it's the capital of United Arab Emirates. We are the holder of the biggest public funded program for health insurance. So health insurance in Abu Dhabi is compulsory and it's mandatory for everyone, UAE citizen and also expats, by terms of either public funded programs or private insurance through employers. So I think I changed the map, but it's not reflecting here, no worries. So as I said, we are the owner. Abu Dhabi Department of Health is the owner of the biggest public funded program, comprehensive program in the UAE. We are working in Abu Dhabi through a third party, which is Daman, the national health insurance company, where Daman is doing the operation for health insurance claims for UAE citizen in the capital in Abu Dhabi. And also it has some programs in Northern Emirates like Ras Al Khaimah, Al Quwain, and other Emirates as well. For Abu Dhabi Health Technology Assessment, our section is under Drug and Medical Product Division, where we have mainly three sections. Health Technology Assessment is one of the three sections. The other one is Drug and Medical Product Regulations, where all the policies, where all the standards for governance and oversight of medications and medical devices are crafted here, and also crafted and overseen as well. Any shortage issues, any drug codings, list of the drugs, everything is overseen in the Drug and Medical Product Regulation. The second section is the Health Technology Assessment, where we are a very young section. We have been established since 2025 only. Last year, where we have been officially assigned a section on health technology assessment for evaluating drugs and medical product as well. And the third section in the drug and medical product is the narcotic and controlled drugs. So briefly, for health technology assessment and the status in Abu Dhabi specifically, it hasn't started only in 2025 where we published our guidelines for industry. It has developed over time because, as I said, because of the mandatory health insurance that was in effect in 2005 when the Abu Dhabi government issued it, and it was enforced. In 2025, in the Department of Health, we started also doing like small footsteps in order to centralize decision on medication, where we had the DOH centralized pharmacy and therapeutic committee. Then we started doing other steps toward institutionalizing the HTA. For example, we had some workshops on performance-based models in 2011. We also had some in 2021. We did like mandating any health technology to be used in hospitals. They should seek our approval first. Then 2023, we also issued, the Department of Health issued the Managed Entry Agreement and Risk Sharing Agreement policy that is available on the DOH website. And then 2024, we started like having a workshop to institutionalize the health technology assessment, and it was done with the Syrian Institute, the well-known European Institute for Health Technology Assessment. And finally, 2025, we managed to issue and publish our DOH health technology guideline that will guide industry, manufacturer, even DOH programs, how to apply for health technology assessment for innovative products. For us, anything that will trigger a new health technology assessment, we have different steps as per any other health technology assessment agency as well. Horizon scans, we do rapid health technology reviews either for higher government personnel, VIPs, higher government agencies. We do our own assessment when we have, for example, a horizon scan, and when we identify anything new worldwide, we do our own rapid health technology reviews. There are also the class reviews, and finally the reimbursement and coverage reviews that we currently do in collaboration with the Health System Finance Division in the DOH as well. In the scope of our guidelines, we cannot do health technology assessment for everything. So mainly it will entitle us to evaluate innovative pharmaceutical, medical equipment and devices, digital health, wearables, where we are working on a fast track wearable guidelines for software as medical devices. Any public health programs as well would be in our scope as well. So we had defined a criteria for whatever we are accepting. So it would be not everything will be under health technology assessment. It would be a high cost, high impact, and we defined a threshold for us in Abu Dhabi. For example, if any treatment is above 100,000 Emirati dirham, or 10 million for one patient, or 10 million dirham per population, it would be the industry will need to apply for it. For the priority focus as well, as I said, advanced medical treatments, ATMPs, biologics, certain devices and diagnostic innovations that need reimbursement as well. Just to understand the life cycle in Abu Dhabi, it starts by the EDE, Emirates Drug Establishment Registration, where they have a framework for registration on federal level and the pricing as well. Then we do in Department of Health the drug coding. The drug coding entitles unique codes for every drugs. And then when we do this coding initiative work, then in the drug code list, there would be an insurance indicator. So anything that is under the priority or under the priority of health technology assessment will be assigned an indicator cost effectiveness needed. So then that drugs will be coded and will be available, for example, for other to see that it is available and registered in UAE, but currently it is under cost effectiveness analysis and evaluation, so it will not be reimbursed until this insurance indicator is updated. When we do our evaluation through the HTA reviews, it will go then through unified procurement program for price negotiation. For specifically, we have a unit for UPP, Unified Procurement Program, for public funded programs in Abu Dhabi. So along when we are doing our evaluations, negotiation will also follow, and then it will be the decision of the DOH. Then it will follow to the PTC on individual healthcare facilities listing and reimbursement as well. Through all this process, there would be monitoring and real-world evidence monitoring by DOH. This is just a brief introduction on how the submission for the health technology assessment occurs. We start by having a pre-initial evaluation. So any company that are going to register their product in the UAE, they come to us first. We encourage them to come to us first. They do like pre-evaluation to know if they are eligible for a full health technology assessment or not. If they are not, they will be exempted according to the threshold that I set for the initial budget impact analysis on our program. If they are entitled and they are eligible for full HTA, it takes us around 60 working days to finalize the decision, including the pricing negotiation, the action, and the recommendation as well. We're currently trying to automate the process to do like a platform for the pre-evaluation submission, for the final submission as well, and to go through all kind of evaluation in one portal. So my section is responsible for the critical appraisal and scientific evaluation. So it will come to us. It will come also to the payer sector, where they evaluate the cost effectiveness model and do the budget impact analysis. And the third layer is the unified procurement for pricing negotiation based on our advised advised cost effectiveness price after the models are being criticized and evaluated. I know I haven't touched yet on the rare diseases, but this is because we are a very recent institute. But I want to highlight that most of our products that we did during 2025 and early 2026 were for rare diseases. So we did the fitasuran, we did the Itvisma, the Zolgensma molecule for older population. We did Dovizate. We did also a couple of CAR-T therapies. And believe me, the decision there when we tackle rare diseases is very hard. It's very hard to take. The models take time to develop. The companies will take time to develop their models because of the data and how difficult for them to gather data from the UAE as well as Abu Dhabi. So I think that rare diseases deserve to have a specific pathway for drug evaluations and health technology evaluations. That's why we are currently working on a pathway specific for rare diseases and for orphan medication as well, that we can, through this new pathway, minimize the time needed for evaluation. Because I know that I said it takes us 60 working days to finalize our evaluation, but the submissions from the companies can take more than 1 year to prepare such file for us to evaluate. So we want to cut down all this time to get the medications for the patient at the right time. For that, we are anticipating in the next 10 years around 60 gene therapies. 60 gene therapies for their rare diseases. They are very ultra expensive condition, and it will risk health technology. It will risk the budget impact for our population as well, and the sustainability of the funding for these products. That's why we believe that outcome-based contracts, risk-sharing agreement can facilitate early access to the medications for these groups. It's very hard to do the outcome-based and the risk-sharing agreement and to have the manufacturer and industry agree to do these terms. But I think they need to also share the risk with us. We are able to risk and pay budget, part of our budget to these uncertainties, and the companies should also have the accountability to share the risk with us as well. And I believe also that AI is very important in facilitating the cutting down the time for evaluation. There are a lot of AI-based diagnostic and treatment tools. So AI will have two things. AI that we need to use it in our internal evaluation to cut down the evaluation time. We have already started utilizing a special agent that is designed for DOH using Copilot. So we have our own information security and IT guys who helped us to do this agent, specific agent for health technology assessment. And we have also been using other internationally recognized AI for systematic reviews. We subscribed with one portal to make it easy for us also to do our systematic reviews and scoping reviews as well. On the other hand, we have the issue of AI diagnostic and treatment tools and the digital therapeutics and the wearables, which also need specific kind of evaluations, and they need their own capabilities building. In summary, so for rare diseases, we need to build our capacity in Abu Dhabi. We need also to have real-world evidence infrastructure enforced. we are, as Department of Health, we oversee all the patient medical records in the Emirate of Abu Dhabi through a health information exchange platform, which is called Malafi. So we can see all the data, all the utilization data, all the outcome data as well is visible for us. So we believe that using real-world evidence infrastructure that is already strong in Abu Dhabi will facilitate using the medication and overseeing the utilization and the outcomes in rare diseases as well. As I said, also the third priority for us is to work more on the outcome-based value frameworks, because most of the medications that I have mentioned, from the 5 that I have mentioned earlier, I think we advise the use of managed entry agreement in 3 out of these 5. So this is very important to couple it also, the outcome-based and the risk-share agreement, couple it with real-world evidence generation to have data generated from Abu Dhabi to prove or to clear any uncertainties. We are working currently on a fast-track HTA process for a specific pathway on orphan drugs and rare diseases as well, because we believe that the normal pathway is not applicable for this medication. And of course, as said previously by the other professors, regional and international harmonization is very important. And we would also be ready. We need to prepare ourselves and be very strong and capable to the influx of all the advanced technologies that is going to be introduced to healthcare system in the next 10 years. So thank you so much, and looking forward to hear the other presentations as well.
Dr. Kefa, thank you for finding opportunity to present today. And also, I'd like to say to our audience that Sechenov University has a MOU with the Department of Health Abu Dhabi, and it's really very productive. You are open to all the discussions, all our suggestions, and thank you for your collaboration with our Sechenov University, and I hope that will also be helpful as Orphan Consortium in this collaboration, because yesterday we announced that we are starting a scientific platform for innovation in the area of rare diseases, because as you know, many treatments are feasible from scientific point of view when we talk about gene therapies, for example, but it's not economically feasible because pharmaceutical companies, it's not profitable for them to develop such kind of therapies. And I believe that our partnership can bring such kind of therapies to global market, because I believe that UAE has very huge opportunities to become pharmaceutical hub, and we can bring those innovations from different parts of the world to Abu Dhabi, to UAE, trying to reach global market for such kind of innovation. Also, I'd like to mention about outcome-based schemes. What you said is the most important mechanism to provide fair access to orphan medicines. Unfortunately, in our countries, in CIS countries, because of the regulation, we can't implement such kind of agreements, and I think this is a huge gap, and we need to walk in this direction. And it's very good that in UAE you have opportunity to use such kind of agreements. And of course, about AI, I think that in nearest years it will change the whole methodology in HTA. And again, I see that UAE has very huge potential in this area. Although HTA started in UAE only a couple of years ago, you have this advantage you have flexibility to use the best technologies, the best methodology which exists in the world. And as all the healthcare is very good digitalized in UAE. I think that UAE will be among the first systems which will implement AI in health technology assessment and also in real-world data, real-world evidence, which is really important for rare diseases. So thank you, Dr. Kefa, and we are moving to next BRICS country. I'm very glad to introduce my colleague, Debjani Müller from South Africa. She's representing University of Pretoria. Please, Jenny, and thank you so much for helping me to organize this session. It wouldn't be realistic to do it without your help, so thank you so much.
Thank you, Nuria and Mohammed, for inviting me. Let me share my presentation. First of all, okay, I know it's not yet, so I don't see what I'm sharing, but do you see my slide? Sorry, I can't hear you. Do you see my slides? Hello?
Jenny, could you switch into full screen mode?
Yeah, I would like to. Okay, now we can see the full screen, right?
Okay, thank you.
Or is it two screens? Or you see my next slide too?
No, it's okay. It's okay. You can start.
Okay. Thank you very much for the invitation. I found the learnings from the previous speakers really important for us and a way forward, like all mentioned, for collaboration pathways between our countries to learn, what is working, what is not working, and how we can improve the process. So I would like to just share some approaches. You will see that I didn't mention even HTA here because of the current, situation of incorporation of HTA in the country. Yes. So this is South Africa with the 9 provinces. It has approximately the population of 64 million, and the healthcare is allocated to 8.3% of the GDP, and out of that population, there is about, the reference is from 2021, 3.6 million rare diseases patient. And the disparities you see is not only between the provinces, but also, between the urban and the rural areas. The young adults have the lowest levels of medical aid, and also the doctor to population ratio is quite low. Like in many countries, South Africa has a dual health system, but the private sector is approximately, catering to 16% of the population, whereas the public sector to 84% of the population. And out of that, the total health expenditure is almost equally divided between the public and the private sector, even though the low number of the population that it is, catering to. And they use the private health insurance services. There are about 18 open medical schemes and 53 much more limited to specific groups of population, such as employment and so on. And the majority of the population rely on the public healthcare system, which is primarily funded by the government. And of course, that leads to the two-tier system. The private healthcare, on the other hand, is roughly 4% of the GDP, serving a smaller population I mentioned, and there are also out-of-pocket payments. It is well-funded, resulting in better equipped facilities, higher staff-to-patient ratios, and superior access to medical intervention. And then here comes then the advent of the NHI, or the NHI that is being the National Health Insurance, which has been being developed over the years, so that to address the spending gap by pulling in resources into a single unified system, which has, of course, because of the history till now, it is not without its own challenges. So the strategy would be with the advent of the implementation of the insurance, that it will address the iniquity in the system and improve the efficiency and the quality of the services, provide value for money, and that should, with the principles of increasing earmark funding, a improvement in the procurement, provision, and pooling models that are, being used by the government, and also the evaluation and the monitoring happening to improve the performance of the public sector, but also as, primary healthcare services that are being provided and have been really put it on the highest important role by the government, that this is what is, has to be fixed properly to provide services or also to lessen the burden on the tertiary facilities. And at the end of the day, then reviewing the private pricing and medical aid schemes, which is also a big bottleneck. In order to do that, the Presidential Health Compact was developed, of course, by the President, and it's an agreement between the different parties, the government, the civil society organizations, where there are many patient organizations, also organizations providing services, labor, academia, to collaborate on fixing the public health system and prepare the country for the implementation of the national health insurance. And out of the pillars, the number 2 pillar is to ensure improved access to medical products, to innovative technologies, and here comes into play the HTA. So, I'll come back to the HTA part at the conclusion of my talk, but I just wanted to give you the challenges of the rare diseases context, and also to the orphan medical products in the country. So the access in the public sector is really limited, in spite of the growing recognition that this is a health issue. There is no dedicated policy on the rare diseases. There are regulatory bottlenecks, as accelerated pathway, which is needed, is not really there. It happens case by case basis, and which results then in delays in registration and the market entry of the products. There is also limitation or limited inclusion of these in the essential medicines list, which is undergoing evaluation, or is evaluated regularly, but also how to include, or the mechanisms of inclusion of these products. So and of course the public budgets, they are prioritizing high burden diseases, and not necessarily for a very small group of the population. And what are the other barriers when you think about what needs to be in place for the or having this kind of interventions into the healthcare? There is fragmentation in diagnostic and treatment pathways. Of course, very few specialist centers, and long delays to diagnosis. Diagnosis may happen in certain provinces only, and then it is not accessible by population, from other provinces. What is currently in practice? It was good to hear about, the managed entry agreements or other ways of making access possible to the patient population. And in South Africa, it is mainly through compassionate user programs or named patient programs that are being provided by the clinician, by the specialist. There are donor manufacture arrangements, and as I mentioned, clinicians' advocacy. Because of the current situation, of course, there's litigation cases and specific pathways happening in the hospitals, which takes place locally. In the private sector, it looks different. There are, special reimbursement mechanisms for insured patients. And as I mentioned earlier on, the civil society, the patient advocacy groups, they play a big role in supporting the access of these interventions for the population. So a little bit about the medical schemes, how it is being accessed through the insured population, also the specialists have to provide a motivation. There are specific hospital benefit plans in place that enables access, case funding, so case-to-case funding, so it's not a generalized law that's there that enables access, such as the Section 28 access for unregistered products that goes through the South African Health Products Agency, the regulatory body. And most schemes, they reimburse orphan medicines when the disease qualifies under the prescribed minimum benefits, but in the real life, rare disease or the orphan products are not included into the prescribed minimum benefits. In case the medicines appear on a formulary, and again the specialist submitting a specific motivation for submission. So, sorry, that is not for me. And South Africa has a single exit price mechanism, and that has been in place to protect the patients, protect the pharmacies and hospitals for out of the way spending on medical products. But on the other hand, it has its own disadvantage, and the manufacturer has to sell this product at a nationally regulated price. It's only transfer and discounts or rebates are allowed, so that with that you can imagine that this is not, that does not allow any kind of other agreements. So like managed entry agreements or outcome-based agreements. So that is the negative aspect of the single exit price that is in place. The hospitals and the pharmacies pay the same basic medicine, and there are regulations made by the government for the annual increase. This is only for the private sector, not for the public. So as I mentioned, the unintended consequences for SEPs for these products, they have limited ability, the manufacturer, to provide, to have this confidential price reduction mechanisms, resulting that many companies avoid launching their products in the market, or they come with later launches of the products, providing no access to patients, and the prices are very high to protect against the global reference pricing. So there was, as I mentioned, the section 28. So for those products which are not fully registered locally, and then this enables access, but of course it creates bottlenecks such as delays because of the administrative burden, and if there is, it will be continued or not, and SAPRA, like you also mentioned, there is a regulation which happens by case, is for the safety, quality, and efficacy, which is also actually a part of the HTA process, which will happen hopefully within the next years, and the patient provides informed consent. I just wanted to mention that that one such case is this is restricted due to extreme cost, and the diagnostic capabilities provided recently will shorten the turnaround time, and the specialist advisory boards are being developed so that they guide the treatment physicians on the care and the funding. Many patients whom I have talked to, they have said the physicians are not aware of what is being or how it is being treated globally or in other countries, and these patients, because of their history, they are more human or more knowledgeable about what is happening or in this space, or for a specific product, where it is being available, under what conditions, or under what reimbursement mechanisms. And here comes into play the different patient advocacy groups who are providing support, not only mental but logistic support for medication. My last two slides I just wanted to share, because we need to collaborate, we said, and not only between the different countries out of the continent, but also within the continent. The SADC is the Southern African Development Corporation, and they came together to put out some principles or gaps in what is happening or not happening within these countries. So there is a need for common definition of what is really rare diseases, a database that has been also mentioned, centers of excellence for specifically for these diseases, capacity building, not only for healthcare workers, I think also for researchers in this field. Social services, inclusivity, what are the cost sharing mechanisms, coverage mechanisms, and how is it, departments specifically in the ministries of health, and that there are, as I mentioned, South Africa doesn't have a national health strategy for rare diseases. So I thought it's not only about rare diseases as such, but we need cooperation for HTA among in the region also. So for some developments within this space is that there are many more advocacy movements because of the necessity. There is awareness among the policymakers that there has to be, some strategies that needs to be in place and that is implementable. Discussion about integrating rare diseases into the benefit design package, and also more interest. I remember 5 years or so ago, I was working on a project on the MIAs and innovative financing, and then there was no, not only not awareness, but appetite for this kind of agreements. Currently, South Africa is, has put together in the public sector a ministerial advisory committee on HTA for different kind of innovative products, and has included also patient advocates into this committee, and they are developing strategies and frameworks for the incorporation of HTA into the public sector. With that, I would like to end my presentation and say thank you for having me here.
Thank you so much, Professor Moller, for this interesting presentation on the South African experience, and also for highlighting the importance of considering the access element within the healthcare system, and also demonstrating the strong presence of the movement, advocacy movement on rare disease to be integrated into the South African National Health Strategy, which is really important, as well as the most priorities that should be considered, the common definition of rare disease that should be recognized by all policymakers, scientific communities, patient associations as well, and doing more collaborative research within the country and also across the regions. Capacity building, establishing excellence centers that you can get like more bold ideas to solve to give solutions, and also highlighting the most important things, which is the health insurance, expanding the health insurance, as well as building unified national health strategies that takes into account the access as well as the rare disease in it. So thank you so much for this insightful presentation. So I'm pleased to introduce the fourth speaker, Dr. Apirud Maglar, researcher in health technology assessment and real-world data. He's affiliated to PharmaQuant in India. Over to you, Doctor.
Can you see my screen?
Yeah.
Yeah, perfect. Thank you. Thank you. It's a pleasure to be here, and thank you to Muhammad and Nuria for inviting me. I will be speaking on a very different topic. I think most of the speakers before me have already laid out most of the issues for rare diseases in developing countries, especially BRICS. And I think a majority of them apply to the case of India as well. And but I would like to go back and speak on something else but just a brief introduction is that I do a lot of work in HTA methods, mostly statistical methods within HTA, and very recently, environmental sustainability. Just a small disclaimer, and the talk of the outline would be that I will just mention the introduction to the problem, that the scale we have in India, but very briefly. And then I will be taking you around a very different statistical problem, which I believe from my experience is not being assessed currently very robustly. This is something that is being even not been assessed in the developing HTA as well, because my primary work is for Europe and US, because I work for a contract research organization, but my academic experience or whatever research experience I have is mostly for India or other developing country settings. So I think this is where I can see the differences very vividly, that we are not exploring those stuff, and these are very critical. So what I will do is I will try to walk you through a very simulated case, where I will walk you through a statistical simulation that I've exclusively performed for this presentation, and then I will try to bind and try to bring out some recommendations, probably, which might be helpful. So the Indian context. So as we all know, like India is a very big country, not as big as China, for example, in terms of land area, but I think we are bigger than China, for example, in terms of population. Now, India is again a developing country. The per capita incomes are not, is still on the rise, but it's still below most of the BRICS, other members of the BRICS. And we do have 70 to 96 million people living with rare disease. And this is a very old estimate. I did not find any more recent estimates as of now. So But to tackle this, the government of India did launch a rare disease policy back in 2021, and this is being updated on a regular basis. And currently, the biggest support that the government provides to rare disease patients is to provide them with a one-time support of 50 lakh rupees, which is around $50,000 in today's terms. But the problem is that it's just a one-time, one-time financial assistance. Like many treatments can go up, can be much more costlier. For example, as we were speaking about enzyme replacement therapies, those things can go into millions of dollars. So I think this is where the biggest help is there. And I will be briefly speaking about the HTA experience, but keeping all of those things aside, and what Gianni just mentioned is that we also don't have a prevalence or incidence-based definition available for rare diseases in India. For example, if we use the cutoffs available for the US, I think we will be grossly underestimating stuff. If we use the cutoffs available for the WHO, I think that will even also grossly underestimate the prevalence. So, and there are much more studies available right now at this point that which shows that disease and health outcomes are very differentiated based on what ethnicity the patient is, what genetic background they are, obviously, and also what kind of racial background within India they are, and what kind of, and access to Medicare is also dependent on the because we have a caste system in India historically, and those things are also probably will have some influence on the access, because those are much more correlated with the annualized incomes that we have. So I think the huge challenges are there. I think which needs a lot of like exploration at this point, and I think the government is trying to do its best at this point. But quickly moving on to the context that HTA in India is very new. In 2018, the HTA body in India, which is called HTA in, which is HTA in India, started, and still now it has been able to do a lot of stuff in terms of all the fundamental work that has to go behind to perform those HTA assessments. The problem is health is a state matter in India as per the constitution. So even this is a national body, each of the states have their own right to even accept or reject. That's what I understand based on the constitutional framework, but it also depends on the political considerations as well. So the current role of HTA in India is only suggestive and not regulatory at this point, which would have been better if we could have achieved that. But we still stick to the PICO framework. But the biggest takeaway from this slide would be that we do not have a cost effectiveness threshold or HTA process separately for rare diseases. And based on the reviews that I have been doing for the last few years, I don't think India has specific HTA reviews available. I don't recall the latest one, but based on like 3 to 4 months old data, I don't see there is a specific HTA process or HTA appraisal specifically is targeted towards rare disease therapies or health technologies. And I think which is something that we need to consider, but it's probably not present. And I think there are a myriad of challenges which is already present as which also apply to the case of India as well. So yeah. Now, quickly moving on to the broader challenge, I think I would try to highlight, and I think the speaker from China already mentioned this. But what I would also mention is that we do have the biggest problem here is most of the trials are probably I would not say probably, they are conducted in very developed settings. And I will come back to that a little bit later. And most of them are focused on surrogate endpoints, short follow-up, observational evidence, and so on and so forth, when we don't have natural history. Even if we have to do a cost effectiveness model, we don't have natural history studies available for many of the rare diseases, because it might not make sense, because many ultra rare disease or even rare disease may not have enough patients to conduct those studies. Recruitment, logistical challenges are a big issue anyway. So I think there is a natural decision-making barrier that I see for BRICS, is that most of this evidence were generated in developed settings where HTA is fully institutionalized, but in our case, it's not the case fully. And most of these results, and we did, and as part of the HTA rare disease interest group, we kind of did a systematic review to find this, and this was and was presented in ISPOR Europe last year, like 2025. So I think we are all more or less aware of this. One of the other aspects would be that we don't have access to prognostication studies. We don't know which covariates affect health outcomes and which are the confounders in the process. That is the effect modifiers. So we are just not aware of many of them. I think this is one of the biggest challenge, because if we don't know, we cannot produce subgroup specific results even within a cost effectiveness model, or we don't know how much like the cost, how good or bad the cost effectiveness of the new intervention will look like against the standard of care. So whatever be the standard of care, like best supportive care, wakeful watching, whatever. But these are the biggest challenges, I think, because we can come and speak things qualitatively, but at the end, if things are not making quantitative sense, I think it's very hard for the general public to comprehend stuff and also to make concrete decisions, because qualitative things are very important to come to the decision framework. But what I understand as a statistician probably is that unless and until we try to quantify, at least to some degree, everything cannot be quantified, but at least to some extent, that creates the natural barrier to making concrete decisions and holding on to that decisions when things are going on the other side of it. So I think that's how I see this problem. Now, I will try to walk you through a very different context, which is generalizability versus transportability. So I think if suppose we have, you can see on the screen, like on the left text, like suppose we have a sample of patients. For a particular treatment, we did a single arm trial, and from there, and those patients were taken from, suppose like few patients from Brazil, few patients from India, and few patients from Poland, for example. Now, we do have two things to assess here. Are the health outcomes affected by covariates or factors are going to differ between these three health systems? So these covariates can be of different types. One can be specific to the diseases. One can be specific to lifestyle status markers or something like that. Third can be very specific to the health systems. Now, if we say that we just sample patients, and if we believe that there are covariates which will not affect them, then we are fine. Like all the patients can be assumed exchangeable between these sites, between these three countries. However, if we assume that there are differences which are coming up because of this covariates or factors, for example, prior lines of therapy. Let me give you a very simple example. Like the prior lines, a number of prior lines of therapy, or the type of prior lines of therapy, for example. Like if like this can affect, or for example, nutritional status. Like developed countries probably will have a better nutritional status versus developing countries. This might happen because of many access challenges we already are aware of. So I think these are factors which might be differing between health systems, and these are not regularly captured or factored into when we are making those decisions. So generalizability is talking about making inferences about the population from which the sample was selected. So it's technically, if you increase the sample size and you develop robust models, you should be able to reach to an unbiased estimator, and you should be able to make good decisions, and that decision should have better reliability. The problem is, if I conduct a study where between health systems, for example, I conduct a study in, for example, in United Kingdom, as you can see on the right, and I try to transport that evidence and I try to draw inferences from Ethiopia, for example, I do have many more challenges to tackle because I don't know, because most of these trials, clinical trials that we are working with were probably done by a global pharmaceutical company, which historically have been part of developed settings. I'm not telling everybody, but historically, the majority of the data, as you can see on the publication that was done by Metcalf and Byung on the right. So most of the targets are being, most of the studies are being done on the from United States, and they are being transported to draw inference from populations within United States. Well, there are a few examples, and only part of the BRICS countries, I do only see Russia here, where one example was there, which tried to transport an evidence from United States to Russia, after adjusting for some covariates. So I think these are but the biggest takeaway from here is that the evidence is not local, which I want to make is something that I see is that it's still not, it's global, but it's not suited to the local needs of each countries. It might be different. Now you might see, they might show that, oh, I'm trying to hand wave at stuff. I'm actually not. Then this is a very good moment and opportunity for me to show you that this is not hand waving. This is actually, there are problems existing, and the statisticians, the HTA statisticians, health economists are actually talking about this. For example, EU joint clinical assessments, the European joint clinical assessments is a very good example where the Eastern European countries are probably much more worried. What happens, because most of the trials were conducted in Western European countries, because many of the context does not suit them. What does this context? That depends on prognostication, differences in healthcare system, differences in training of the doctors because of the assumptions the models are making to make indirect comparisons. Now, to just show you, I have done a simulated study, and that's the biggest tool as a statistician I have, is that I do have a developed setting where a drug A, which suppose an enzyme replacement therapy, was studied for a sample size of 80, and I want to transport that to India. Now, drug A is a potentially very innovative enzyme replacement therapy. SOCs represents the standard of care. Now, I have individual patient level data because the company will be making submission to the HTA body. So I just have IPD data available for me, for example. But for India, I do not have individual patient level data. I might have standard of care, old published studies with just response rates or just few graphs available from the publication and just some baseline characteristics, which I want to adjust. And it might not be enough. But this is the challenge that we regularly face when we are submitting for HTAs. And I think the challenge here is to estimate a reliable average treatment effect, which will be applicable to the Indian context and not the Western context, because I need to make decision within my jurisdiction and not within the other jurisdiction. So yeah, my bad. Sorry. Yeah, I clicked on something else. Okay, so the statistical simulation setup that you see over here is my aim is to not demonstrate the naive estimator. If you don't adjust for anything, what happens? So you can see the data generating mechanisms that have, it's typically based on the individual treatment effect. And there are 3 covariates, which is baseline disease severity, age of initiation of therapy, and nutritional status. These are just hypothetical case examples. It can be anything. And that's why prognostication studies are, and effect modifier analysis is very much important for us. And that will be determined by RWA's clinical opinion for a long time. And we need to arrive at these covariates. Otherwise, we will not be able to assess how much differences are this creating. So, but the caveat in this kind of methods is that you need to assume a lot of stuff. And on top of that, you need to ensure that all of the covariates of interest or all the confounders are fully adjusted for. So, which is obviously a very tough thing to achieve, even in developed settings, because I'm coming from that experience, so I can also mention that. So our estimans is the average treatment effect, which is conditional on the Indian population, that I want to predict stuff for India, nothing else. So I do have 4 methods. One for the naive estimator, the method E1, the E2 is, the method 2 is looking at partial adjustment only on X1. The third is full adjustment. These are weighting adjustments. And the fourth method is something as a marginalization, which is much more sophisticated and much more robust, what I believe. It's a regression that's adjustments. So yeah, and so the key results that you see here is that the baselines between both the studies vary very much between all of these covariates, which you can obviously see from here because of the graphs. And that is what the primary reason of concern is. The third is, now, after conducting the analysis, I know I don't have much time here, but what I can show you here is that the blobs that you see here, the blurbs, is that this is the differences in effect modification due to each of these covariates. And this is huge. It can't come at that level. It depends on how I have simulated the data. That is the caveat. But just to show an example, I have seen in real world practices where the differences between 2 health systems were so different that end of the day, this kind of models will never be able to run. So I think, or I have seen examples where we believe that the health systems might be different, but the results did not turn out to be different because of various similarities, which is confounded. So we need to adjust and we need to strive for this. So the key results, as you can see on the screen, is that the naive estimator, if you're not adjusting for everything, and that means we are blindly believing anything, that's somewhere down the line. But as we keep on adjusting, things are moving in the other direction, right? With the most robust and most smallest confidence interval, that is in terms of uncertainty, you can see on the fourth method. Now, it depends on what context we're applying those methods, but it needs to, but the point that I'm trying to prove here is that we need to start assessing this issue more regularly for rare diseases, because what I believe it is not being assessed. Second is we need more focused evidence generation for BRICS CIS countries. And that means on effect modifiers, we need to strive for more mature data, that because I've been listening that we need much more risk sharing agreements and all of those stuff. But we can achieve those. But what we can ask the manufacturers is that, okay, we'll go for risk sharing agreements, but in the meantime, you should be collecting more data, and you should be satisfying my methodological needs as well. So yeah, I think the key takeaways are there, that we need to be more focused about BRICS CIS countries in terms of evidence generation. We need to be more context specific to ours. And this matters because, as the earlier speakers were mentioning, that in developed settings, if a global reference price is set, it becomes very hard for the developing countries to go out and negotiate an even better price, like the lesser price, even though the outcomes. The only way you can tackle this, I would not say tackle, the only way you can defend this is that asking for more robust analysis or more robust data. So, and what comes next is, I think, joint collaboration in this matter, as Nuria was mentioning, I think would be of great interest. So yeah, thank you. And thank you for this. Thank you for inviting me.
Thank you so much. Thank you for your reflections regarding the potential of this partnership within BRICS. I fully agree that there are many aspects which we should consider, especially regarding clinical trials, because we have a huge population in our countries, and if we organize this collection of information properly, we will have more evidence. And yesterday we discussed different aspects of this potential partnership. And of course, I think we need to start with mapping our capacities, our research and development projects, because we don't know what is under development in China. I'm talking about rare diseases, about orphan drugs. We need to understand clearly what is developing China, what is developing India and other countries, not to duplicate our efforts. What for? We deal with rare diseases. Just let's collaborate and let's split the market. If we direct all our volumes from all countries to one producer, then of course we'll decrease the prices and it will be more accessible for BRICS countries with huge population and with budget constraint. So I think we need to be more clever, to develop our own approach to deal with rare diseases, because we need to partner, and then it will enable us to decrease our costs or to increase our coverage. So at least to increase our coverage. So Abhirup, thank you so much. I hope that we'll continue our collaboration. I also wanted to ask you about horizon scanning in India, because this is what we need now to understand the pipelines of different research institutes, of pharmaceutical manufacturers. But we'll stay in touch. I know that you need to leave our meeting, so thank you. And we move further. Now I'm glad to introduce our colleagues from Iran. They also participated in our plenary session yesterday, and we organized together a webinar a month ago where we discussed MCDA approaches for rare diseases. So thank you colleagues, for your participation in our events, and I'm glad to introduce Dr. Ali Reza Limanesh and Mohamed Reza Mobinzadeh from National Institute of Health Research, Tehran University of Medical Sciences. Please. Dr. Ali Reza, please choose English channel. You can see 3 dots at the bottom of the page and then select English channel, because now you are in Russian channel. We don't hear you.
Yes. Can I start?
Yes, please start.
Doctor. Okay, thank you much. It's my pleasure really to be in this meeting. I'm Dr. Oli Aymanish from the Islamic Republic of Iran. I'm going to explain a bit about the
Dr.
story
Ali
of
Reza, sorry, could you choose full screen for your presentation?
Yes, sure. Is it okay right now? Yes?
Yeah, okay, thank you.
Okay. You know, the story of the HTA and implementing that in the health system of Iran is a long story, and it starts from about 2 decades ago in 2007, when myself and some of my friends were returned from UK to the country after graduations and try to establish some units for HTA and guideline at the Iranian Ministry of Health. And it is near 2 decades that we did that. We try to develop different institutions for the HTA and even for the training of the students. We have at the moment a master of HTA in different universities of Iran. And at the moment, I can tell you that during these 2 decades, we have conducted more than 200 HTA in the country, and more than 600 different protocols, guidelines, and service standards have been developed and implemented in the health system of the country. So I'm going to explain this experience in the orphan disease and orphan drugs, the rare disease and orphan drugs. Not going to bother you with the problem that were mentioned by other speakers about the challenges that we have all around the world about the rare diseases and the orphan drugs, including the, for example, the scarcity of the evidence and low prevalence of them, and also high morbidity, chronic disability, and significant reduction in quality of life of the population. Let me explain about doing an overview about the health system and health insurance system in the Islamic Republic of Iran. As I mentioned, we have about 60, more than 60 medical universities which are authorized for the medical education, both for the medical education and the health of the population under the coverage. So, and more than 1,000 hospitals, 1,100 hospitals, and also more than 30,000 primary healthcare units all around the country. So we have a service coverage and insurance coverage inside the countries with 3 levels of primary healthcare, secondary healthcare, and tertiary healthcare. And in each one of them, you can see that we have different services that are covered by the insurance organizations, mainly by 2 big insurance organizations, which are called Iranian health insurance organizations and social security health insurance organizations. And these are the number of the services, medicines, laboratory services, imaging services, and also medicines and other services, specialized services that are covered by each levels of in each levels of care by the insurance organizations. In terms of the rare diseases, we should have more than 3 million patients, but at the moment, around 7,000 of them have been registered. Near 500 identified group of rare diseases, but about 100 of them are covered by the insurance organizations, because many of them just were identified recently, and we didn't know about all of them. As I mentioned, there are problems with the evidence for the rare diseases and also for the registration of them. But recently, we have established one system for registry of them, National Rare Disease Registry, that started for the registration of them, and more than 7,000 of the patients at the moment voluntarily have been registered in that software. So in 2000, based on the statistics in 2018, these orphan medicines accounted for only 3.2% of total pharmaceutical expenditures, and 71% of the costs are covered at the moment by the national insurance organizations. And we know that this amount are increasing very rapidly. So we have to have a system for reimbursement of the budget between these patients and these diseases. We have, other than the rare diseases, we have special and hard to treat diseases such as cancers and so on, that for that reason in 2022 a fund was established with the name of a special and hard to treat disease support fund under the supervision of Iran Health Insurance Organization, with the aim of expanding insurance coverage and providing financial support for the diagnostic and therapeutic services, and improving equity in access to healthcare for vulnerable groups. So at the moment, about 178 million US dollar is allocated to this fund, and this is a formal one, number, but for every year, some part of that is allocated in reality. For example, in 2002, only 40% of that, because of the limitation in the budget, have been allocated to that. We at the National Institute for Health Research, which myself and Dr. Mobinizadeh are the member of the Department of Health Economics, have done two big projects with the order of the Iranian Ministry of Health and Medical Education. They requested us to do the two projects. One of them is, providing evidence for the situation of the basic health insurance package of the country, and doing some reforms on that, and providing evidence of the cost effectiveness for different services that are under coverage. That I show you that more than 10,000 medicines and services are under the coverage of the medical or health insurance organization. So the Ministry of Health is going to somehow correct the coverage of some services which are not cost effective. In the second order, we did one study for the distribution of the national budget, which is allocated to the rare diseases, between these near 500 rare diseases. So we invented a model for the distribution of that limited budget for the rare diseases, and the result of those studies have been mentioned here in the papers, and Dr. Mobinizadeh is going to explain in very, very quickly about the result of those studies. In general, we have many gaps in fund allocation, coverage, and in implementation of the national policies for these studies. At the end, I want to introduce our journal, which is Health Technology Assessment in Action. We established it in about 10 years ago, and it is indexed in many databases, including the Scopus, and you are
Dr.
welcome.
Alireza, sorry to interrupt you. I'm really sorry, but we are behind schedule because we should finish at
I finished my presentation.
1:15.
Just
Please, 2 minutes, because we don't have time for Dmitry for his presentation.
That's okay. Dr. Mobinzadeh, if you like to come and explain in 2 minutes.
Hello, everyone. I'm so here. I'm so happy to this meeting. Our project and our models is on the base of the MCDA with the type of multi-objective decision making with the kind of the linear programming. We design it for defining the shared budget coverage for orphan medicine products for diseases such hemophilia, SMA, cystic fibrosis, multiple sclerosis. And the goal of this project is on the basis of the maximizing the quality. And these models was designed with the GAN software and with the considering this constraint: annual cost preparation, number of eligible patients, government budget share, policy adjustable weighting for better understanding of the health system situation. Okay. Thank you very much. We are ready for the better collaboration and exchange knowledge for between BRICS countries around these kind of models. Thank you very much.
Thank you so much, Dr. Manish. Thank you so much, Dr. Mubinzadeh, for this interesting experience from Iran that actually highlighted the strong establishment of HTA in Iran. And also what is interesting is integrating or introducing the educational program for HTA as a master program, which is really needed for the region, for our region at least, as well as, establishing a new journal that can support the researcher from low middle income countries to publish, to share, to disseminate the evidence on HTA. And also the collaboration between academia, ministries of health or health authorities, which is very useful for HTA. Now, the last but not least, I would like to introduce Dr. Dmitry Shurov. He's from Center for Horizon Scanning and also representing Chitnov, the university in Russia. Dr. Dmitry, over to you.
Yeah, I'm here. So I will share my slides.
Yeah, we can see it.
Yeah. So dear colleagues, thank you for the invitation and for the opportunity to discuss orphan medicines with representatives of BRICS countries. So I will focus on the Russian system, the healthcare organization and financing, drug reimbursement, orphan drug pathways, HTA, and possible joint actions through the BRICS Orphan Consortium. So I'd like to start with the Healthcare Horizon Scanning Center at Sechenov University. The center was established only last year. The core activities of Healthcare Horizon Scanning Center include technology, analytics, and foresight. Secondly, the center supports public decision-making. Thirdly, we provide the trainings for different stakeholders. There are some other activities which you can find on a website of the center. The center anticipates clinical value, future demand, budget impact, implementation barriers, and the conditions required for effective integration into healthcare. The center works with 3 groups of partners, with the government and regulatory agencies, with manufacturers, and with clinical and academic partners. In short, the center helps move from reactive reimbursement decisions to proactive planning, which is particularly relevant for rare diseases and high-cost innovative technologies. Russia has a system of state guarantees where a large part of medical care is provided free of charge for patients. So public financing comes from 3 main channels. So the compulsory health insurance, the federal budget, and regional budgets. The compulsory health insurance is the core financing channel for guaranteed medical care, especially inpatient care. The federal budget finances federal programs, clinical approbation, and drug provision for beneficiaries. Regional budgets finance regional healthcare systems, benefit programs, and partly high-tech medical care. For patients, inpatient care is free within the state guarantee program and compulsory health insurance. Medicines used during hospitalization are also free of charge at the point of care. And this matters for orphan medicines. If a patient receives therapy in a hospital, the drug should be provided as a part of care. However, practical problems may arise when the medicine is very expensive, when the disease is not the main reason for hospitalization, or when treatment is needed outside the hospital. Reimbursement of drugs. Drug reimbursement in Russia can be divided into inpatient and outpatient provision. In inpatient care, medicines and medical devices are provided free of charge for covered hospitalized patients. Financing comes through the state guarantee program, compulsory health insurance, and DRG-based hospital tariffs. The essential drug list is the main public financing reference list. Outpatient reimbursement is more fragmented. Coverage depends on patient eligibility, patient categories, and disease-based programs. Some patients receive medicines because they belong to a protected category. For example, people with disabilities or small children. Others receive medicines because they have a disease included in a specific reimbursement program. For orphan drugs, several dedicated pathways exist. At the federal level, Russia had the high-cost nosologists program, often called the 14 high-cost nosologists program. The majority of covered diseases in this program is orphan diseases. Another important federal mechanism is the Circle of Kindness Foundation, which provides medicines for children and young adults up to 18 years old with severe and rare diseases. At the regional level, there are the 17 diseases list financed initially through regional budgets, but from this year, the financial support is provided from the federal budget to regions with low financial capacity. Obviously, federal mechanisms provide more equal access than regional, and that is why centralization of drug procurement is one of the directions for the system development. HTA in Russia. So a health technology assessment is a key element of reimbursement decision-making in Russia. And since 2014, HTA has been compulsory for medicines proposed for inclusion in reimbursement lists. The HTA methodology is fixed in rules. The assessment includes clinical effectiveness and safety, quality and level of evidence, economic evaluation, and cost effectiveness. budget impact, and other consequences for the healthcare system. So additional therapeutic value and local production are also considered. The requirements for orphan drugs are a bit different. So randomized clinical trials conducted outside Russia may be used, and the small size of patient populations is recognized during assessment. Entry thresholds for the quality evaluation of clinical and pharmacoeconomic data, including budget impact analysis, are adapted for orphan medicines. However, further development is definitely needed. Today, there is no fully developed system of managed center agreements and no compulsory reassessment mechanism for all orphan medicines. For high-cost technologies, reimbursement should be connected with follow-up evidence generation and periodic reassessment. From the Russian perspective, there are 4 development priorities, such as managed center agreements to share risks between the payer and manufacturer when evidence is promising but still uncertain. Second, systematic collection and analysis of real-world data and reassessment of effectiveness, safety, and budget impact, and possible reassessment of initial conditions for drug purchasing. Third is centralization of procurement for orphan medicines to reduce regional inequalities, improve bargaining power, and make access more predictable. And the last one is development of HTA methodology for orphan medicines, and here MCD might be a good option. There's where BRICS cooperation becomes highly relevant. So I fully support the activities of the BRICS Orphan Consortium, and our countries face similar challenges, and the consortium can help us move from separate national discussions to practical joint work. So I see 3 priority areas for joint action. The first one is joint horizon scanning. The second one is joint clinical evaluation and real-world evidence exchange. For rare diseases, no country has enough data alone. The third is joint price negotiations and procurement approach. BRICS countries could explore coordinated negotiation or procurement models for selected orphan medicines. I also strongly support the idea of preparing a joint article on HTA systems for orphan drugs in BRICS countries. So it would be a useful academic publication and a practical foundation for future cooperation. And to conclude, Russia has a structured system of healthcare financing, drug reimbursement, and HTA with important federal mechanisms for orphan drug provision, especially for selected high-cost nosologies and for children and young adults through the Circle of Kindness Foundation. And at the same time, challenges remain: regional inequality, limited access for adults, evidence uncertainty, and the need for more flexible reimbursement tools. Through the BRICS consortium, we can develop joint horizon scanning, joint clinical evaluation, real-world evidence exchange, and possibly coordinated approach to price negotiations and procurement. So, and I support this direction and the proposal to write a joint article on HT systems for orphan drugs in BRICS countries. And the last thing I would like to say is that I sympathize each patient, and I believe that our joint actions will make our healthcare systems more sustainable, and we could provide improve access to medicines and provide better care to these patients. Yeah, thank you for your attention.
Thank you, Dmitry. And we are behind schedule. Unfortunately, we have time for discussion and for questions, although I have many questions for my colleagues, but we need to finish our session because we have the next session. But I really appreciate that, as I understand, we all support the idea of joint publication. And of course, we need to plan our next steps. Maybe we could plan interregional workshop or other actions. Anyway, I suggest to stay connected, and I'm happy that we can build this network. And I suggest connect and plan the next meeting, not only the article, but maybe other activities, because we have lots of possibilities how to work on access, to work on HTA, on methodology. So thank you so much. Thank you for your time, and I hope to meet soon.